Hi, I'm Jessica Mayfield, clinical lab educator. I've worked here at Providence for almost 16 years in almost every department in the lab. My love is microbiology though, and I'm here to introduce you to the lab. Here are a few objectives that go over what I'll talk about today. We'll go over just basic Gen Lab information, labeling, order of draw. We do talk quite a bit about blood cultures and the blood bank, and then a little bit about the tube system and our test directory. So today's takeaway really, our lab results that come out to you are really only as good as the specimen that we receive. We can control what's happening in the lab or the intra-analytical phases and post-analytical. However, pre-analytical, we do find most of the errors occur during this phase. So we do educate quite a bit around these variables. And examples of these would be, drawing in the correct container, the correct test being ordered, avoiding hemolysis, clotted samples, and so on. So just some general info about the lab. We do have about 150 caregivers. A little over 50 are medical laboratory scientists, so they're the ones doing the testing. And probably 60, 70, 80 are phlebotomists, our processors, and our client services department. We have labs both at the Colby campus, which is our main lab, and at the Pacific campus we have a small sort of stat lab that services the pavilion and the floors. And our microbiology lab is also located there, although they will be moving soon. So I'll briefly go over labeling with you. Okay, so we do have two different labeling systems here at Providence. There are several floors that use Transfusion, which is a positive patient identification system. It's much safer, and when that sample's reached in the laboratory, we aren't relabeling it. So it's safer because you have to scan the patient's band. The tests pop up in the system. You go through, you choose the test that you want, and it prints right there by the bedside. You take those labels and you label your samples. What's great about the labels is that it includes date, time of draw, the type of specimen you're supposed to collect. So you can see it says MNT green for mint green, and it will have the collector's ID on there. These are all things that are required according to our labeling policy. So the floors that don't use Transfusion typically have to use Epic chart labels. Those are missing key information, and we do require that this information is on those labels to accept the sample. So make sure that you're writing date and time, your collector's initials, and if it's not a blood sample, we do need to have the source and laterality. Here's a little flow chart showing the difference between Transfusion and Epic chart labels. We hear sometimes, my printer isn't working or so-and-so, so a Epic chart label is used. Unfortunately, it takes quite a bit longer once the sample's down in the lab when we do receive tubes with chart labels on them. So you can see here, Transfusion, we just grab the tube from the station, we check the label, make sure CBC is on the lavender, and we load it right away on the input module. As for Epic chart labels, it's quite a bit longer, as you can see from this diagram, and we are relabeling the sample, which also always adds a chance of error. So here's a picture of a properly labeled tube. This is a mint green tube. You want to hold the tube with your left hand and label with your right. Make sure that you can still see that color strip. If you look right under the label, you can see the mint green color strip. This is because our instruments take the cap off, and once that cap's off, if we need to add on any additional testing, we need to know what type of additive was in the tube. Depending on the additive, we may or may not be able to add that test that's being requested. We also need a window so that we can see how much specimen is in the tube and whether or not it's hemolyzed. And here's a little video of Val. She's one of our chemistry superstars, Here she's looking at multiple monitors. They all control different things. Some of them are a lab information system. One of them's the instruments. One of them's the line, which is basically like a train track for tubes. I think she's actually calling a critical result in this image. But what's great about this video is you can see how quickly the instrument picks up the samples and how important it is that the label is towards the top of the tube so that the instrument can read that barcode. So the lab has a separate IT system. It's called Cerner, which does interface with Epic. Unfortunately, the info from Epic does not always cross into our IT system, depending on where it's been entered in Epic. So in patients with multiple body fluid specimens collected, if the cups themselves are not labeled, there's no way for us to reliably tell what the source is. We did a 4-day audit in August, and the body fluids were only labeled correctly 2% of the time. So here's an example of 4 different fluids. I usually ask during the presentation if anyone can tell me which one contains pleural fluid. They all look very similar. So number 1 is pleural fluid, number 2 is peritoneal, number 3 is urine, and number 4 is synovial. And as you can tell, they all look very, very similar. So what sort of started this audit that we did in August, we had 2 sample containers filled with yellow fluid received in the lab with the same patient label. So it was the same patient, but there was no specimen type written on the label. They appeared identical. Epic had 2 orders, one for a pleural fluid cell count and chemistry testing, and the other for a urine needing a UA. So which is which? What happened was there was a UOR because the patient's body fluid was run as a urine and results posted into Epic, and that body fluid was tossed because they thought it was urine, and we only keep urines for 24 hours. Results are significantly different after 24 hours for urines. Fortunately, they found it in the biohazard bin, and they were able to rerun it, but it does show you how important it is for us to have those labeled properly. Another example would be time draws. So in this slide you can see Vanc trough time draw was ordered. We received the sample without a time. How do we know when it was drawn? And so for example, here you can see this is what the results look like in Epic. That time that the arrow is pointing to is actually hand entered by us. So when we receive Epic chart labels. And the policy had been when there's no time to put 10 minutes before it was received in lab, which is likely not correct. And it is very important that we have the accurate time for these time draws. And then another example, which we'll talk about massive transfusion protocols in more detail later, but they require periodic lab work to track the patient's H&H and coag testing. We receive multiple tubes at the same time of H&H and coag orders during these MTPs. And when none of them are labeled with a time, how do we know which results to order, to enter for which order? And it does matter because we need to be checking the H&H and coags after each transfusion. So we'll go over order of draw, volume, mixing, and contamination. So there is an order of draw. Additive carryover can impact test results and cause false values. The order of draw is shown here. So for example, we don't want to draw a lavender, which contains potassium EDTA, before any mint or chemistries. So lavenders have the potassium. We don't want to add that to the chemistries where we're testing for potassium. And EDTA binds to calcium. We also don't want to add that to any chemistries where we're testing for calcium because we don't want it to look like there's less calcium, a lower result. Another example would be we wouldn't want to draw gold before a blue. Blues we're testing for clotting time, and golds have clot activators in them, so we don't want to add any of the clotting activators into that blue top tube where we're running the PTTs. So here's an example. This was a couple months ago. Our chemistry technologist questioned these critical results on this patient's BMP. So what happened? They kind of had an idea, so they called the floor. I think this was at the pavilion, and they talked to the nurse. They were having some troubles with the IV and the line, and so after drawing into a pink top tube, they realized, oh no, I actually didn't need blood bank testing. I need a CMP or a BMP. So they had poured the tube from the pink top, the blood from the pink top tube into the green top tube for chemistry testing. Unfortunately, the additive in the pink top tube is potassium EDTA, so the potassium was very high, and as you can see, the calcium is very low from that EDTA binding it. When they were redrawn, you can see the results on the right. Everything looked back to normal. So please don't transfer blood from one tube to the other. Most of them have additives. So fill volume and mixing. This is a big deal with sodium citrate tubes. You want to make sure that you are in between the max and the minimum fill line, so you don't want to be pushing with a syringe over that max fill line. It will affect the clotting time. And obviously you want to make sure it's filled all the way. As far as mixing, a lot of people don't know that the additive is actually on the side of the tube. So when you're mixing, and this is the proper way to mix, you invert it 4 to 6 times. An air bubble goes to the top, you mix it again, air bubble goes back up. Each time that the air bubble is moving, it's creating friction on the side of the tube and rubbing that additive off, which is getting the additive in there, and it can mix with the blood properly so we don't have clotted samples, and we don't have to call you guys to recollect. So just like this. Don't shake really hard. Make sure you invert it. We need to get that mixed in there. Line draw contamination. So we do ask our phlebotomist if there's an IV to select the best option. So first choice, they'll look for a spot on the opposite side of the arm. Obviously, sometimes that's not available. So they may ask you to pause the IV for a draw. And typically we try to pause it for at least 5 minutes so we don't contaminate the blood sample with any IV fluid. Here's an example of critically low results due to dilution effect of IV fluid. You can see once the patient was redrawn, the results were quite a bit different. So it's just really important to make sure that we pause that IV before we're collecting that sample. Microbiology, my favorite. So this is actually a picture of our blood culture instrument. You can see the little blood culture bottles incubating happily in their little cubbies there. All right, so you can see here, here we have Kaylee on the left reading a gram stain. They read it and they put the results in right away and give you a call if it's positive. And you can see on the right Rachel looking at what it looks like a urine culture in our biosafety cabinet. So for blood cultures, it's important to note, obviously we need to collect them before antibiotics are given. We need at least 8 to 10 mils per blood bottle. And for children, it does depend on their weight. If you cannot collect that 8 to 10 mils per bottle, please fill the aerobic, the blue top container first, and then put the remainder in the anaerobic. So don't split half and half. Put most of what you have in that blue top. If you don't have enough for the anaerobic, you don't, but we need that aerobic filled completely. And I'll explain why here. So in microbiology, once the blood culture bottle is loaded on the back T, which is that analyzer you saw before, the sensor scans for a color change every 10 minutes on the bottom of that bottle. That color change is triggered by an increase in CO2 due to microorganism metabolism. And then that back T analyzer will beep when a color change has occurred, and then the microbiologist will work up the culture. So obviously more blood volume, we will have that CO2 reaction happening sooner, and we will be pulling the bottle out and working it up and giving you a call sooner. We also only hold them for 5 days, so if we don't have enough blood in there to create that reaction, it could go undetected when there is actually an organism there. And this is just a reminder to, if you do need to collect a blood culture, obviously it's very important to not contaminate it. So really use pressure and friction when you're using that ChloraPrep applicator on the patient for 30 seconds back and forth. Let it dry, and please never retouch the site. Don't alcohol your finger and retouch. It does cause contamination, which takes, I think it's an additional 24 hours to work up, and we're calling you when it's not a real infection. So the blood bank, there are a few slides on the blood bank. It is a pretty big department, and obviously they're pretty strict because they need to be, so that we're getting the right blood out to the right patients. So they use type and X identification bands to ID patients. This is for all patients who have a potential of receiving blood products, and it's in addition to the hospital ID band. You can see a picture of it here. So because they are handwritten, it can be a little complicated to label these properly. So I will go over that the next few slides. Here's a graph you can see. We were doing pretty well in September. There's kind of a spike. It looks like we're going up a little bit in February. So we just try to continue to educate and provide resources to make it easier for everybody. So you draw a pink top, that potassium EDTA tube. The key here is to use a black ink ballpoint pen. Make sure that you're pressing hard enough, because you'll be taking that sticker off and you'll need to be able to read what you wrote underneath that sticker. That will be the patient's band that they keep on their arm. It does have to be written as last name, first name. A lot of people recommend just writing in all capital letters because it's clearer. So last name, first name, date of birth, legible, and then the date, time of draw, and the initials of the person drawing. Some people ask, can you use the medical record number? You can, but it has to be exact, and there's a lot of zeros in those numbers, and it's really easy to miss or add one. So they typically recommend using date of birth. Also, they don't recommend putting a middle initial. If it's too close to the first name and looks like the first name, they will have to reject it. So you've completed that type and X label. You pull that sticker off. You place the sticker on the pink top tube. You'll ask the questions to complete a blood bank red history card. There's a picture of that here. Then you remove the extra yellow ID stickers from the patient's armband, type and X band, and you send it to the blood bank with the filled and labeled pink top sample. So what will come down to us will be in a double bag, that pink top sample, the extra yellow type and X labels, and the red history card filled out. Here's an example of a properly labeled type and X. Last name, first name, date of birth, date, time, initials. The letters and numbers on that yellow part, that's if they ask for a type and X number, that's what they're talking about. So say the sample you sent was QNS, but the label's still okay. You don't need to reband the patient. I'd say anytime you think about cutting a patient band, I would call the blood bank, because if the band is good and they've already worked up the sample and have units ready for the patient, if you cut that band off and reband with a new type and X ID, all of the work they did has to be completely redone, which can be pretty time consuming, especially if the patient has an antibody. That can take 4 to 6 hours to rework up. So we have these secondary type and X labels. Basically it's the same thing, last name, first name, date of birth, and then if you can put a little type and X ID sticker there. If not, just write it out. And the ID does include the letters and the numbers. So here's a little job aid for the confirmation type. If the blood bank doesn't have a previous historical type on a patient, They will put in an order for the second type. And here's a little example and work aid that's been pretty helpful to our staff for collecting those. It does need to be a second caregiver, different collection time, and you can use a generic Transfusion label or the blood bank white label I showed you before. So if you haven't heard of them before, massive transfusion protocols are, it's basically a protocol to allow for blood products to be available for quick administration and life-threatening uncontrollable hemorrhage. It's a continuous release, so once this is ordered by the provider, we are continuously releasing blood products to that patient. These are pre-assembled kits. So I believe there's 2 kits in the emergency room, emergency department at the Colby campus, and 1 kit at the Pacific campus in the lab. And the key here is make sure that you call blood bank right away when one of these is initiated. There I'll show you a picture of why in the next slide. And then also make sure anytime you pull those kits out, to put them in the cooler, to use the cooler. So here's the fridge in the ED where the MTP kits are held. There's 2 of them. I know the OR has frequently come down, and they can pull from there as well. You can see the coolers here, so you want to take out the ice pack, put the MTP kit in, place the ice pack on top, and close the lid. And only take 1. The other kits are for other situations, other floors. So after you take that 1, you'll be working directly with the blood bank to get more blood products. So like I said before, it's extremely important that you call the blood bank when MTP is initiated. All blood bank orders print on that printer. You can see the red circle around it. It just prints an order. There's no call. They don't know that an emergency situation is happening and you've initiated an MTP unless someone calls. It will just sit on the printer until they get it with their routine stuff. So there's no really reliable way to find out about an MTP quickly without that call. All right, we are almost done here. Non-blood specimen collection. Just the key thing here with pertussis swabs, flu RSV swabs, make sure you're checking your expiration dates. We do frequently receive expired swabs, and we can't run those. We do have to reject that. And then we do run 1 in a 7-day period. Please note flu results post into Epic, so it's one thing we will not call. Urine collection, send down the orange sterile cup. Make sure that lid's on tight. Usually I will turn it a couple times to make sure that it's tight and it's not misaligned. We have had to shut down the tube station when one leaked out of the container and the bag, and they cleaned it, and everybody had to walk their samples down. And then also please note that send it as soon as you can after collecting it. Time delays do lead to inaccurate results. For example, decreased glucose from glycolysis and bacterial use, decreased bilirubin if it's exposed to light, photooxidation to biliverdin, and so on. Increased bacteria due to multiplication, especially if it's room temp. So we really want to receive that cup as soon as possible so we can put it into tubes with the proper additives to stop that from happening. And then C. diff testing. Don't send us formed stool. It should not be hard. You shouldn't hear it when you shake a cup. It really should be Bristol stool chart type 6 or 7. And no testing if the patient has been on laxatives the last 48 hours. So this is a newer slide about COVID testing. You will collect an NP swab and inoculate it into a VTM or viral transport media. Break that swab off and cap it tightly. Make sure the tube, the specimen is capped very tightly, and double bag it in 2 leaky-proof biohazard bags when you send this through the tube system. Obviously for the same reason as the urine. Please note those M6 viral transport media bags that the tubes come out of, those have holes in them, so you need to make sure that you're putting it in 2 separate leak-proof biohazard bags. We do perform this test. As of tomorrow, we'll be performing this test at the Colby campus in our lab with about a 2-hour turnaround time. Our tube station is number 10. Again, double bag all tubes sent through the tube station. We have a critical readback policy. After the lab gives verbal results, we need you to read it back. So give the patient name, date of birth, test name, result, and your full name, first and last. Body fluids are walked down to the lab. We do have a little sign out clipboard when you bring them down to say you brought them and we received it. And as well as Plavix PFA testing, so we don't aggravate the platelets. We don't want to do that until we're testing. Here is our test directory. You can reach it under Departments, Laboratory, and Test Directory. You can find everything you need, turnaround time, what to draw. Although if you're using Transfusion, it'll say it on the label. Here's another example. You can see specimen handling, stability, minimum collection volume. A lot of people like to know what the minimum collection volume is, and turnaround time, where it's being tested. So place to service, for example, is PRMCE. And that is it. If you have any questions, please feel free to reach out to me or call the lab. We want to help as much as we can. Ultimately, it is the best thing we can do for the patient. So thank you.